Hello, everyone. Thanks for tuning in to this week's episode of the Health Me podcast, episode number 46. Remember to leave a like and subscribe so you don't miss any updates. This week, we had the opportunity to talk with an orthopedic spine surgeon to learn more about life as a surgeon. From our conversation, we learned some of the differences that make spine surgeons unique, where the field is growing, and how to best prepare and plan for surgery. Furthermore, we go over other parts of where surgery and physical therapy overlap. No, not like physical therapists are cutting people open, but instead discussing why the spine is more prone to injury and how this is leading to high economic changes nationwide. Of course, links of everything will be provided in the show notes and timestamps will be listed below. Please enjoy my conversation with Dr. Michael Venezia. Today, we're going to be discussing many things in regards to surgery and basically what the future holds for the field. But I would like to maybe just describe your current role and credentials. So if you wouldn't mind, maybe just including what you're doing currently and then where you work.
Yeah, so I'm currently a private practice orthopedic spine surgeon in my second year of practice. Finished my fellowship at the University of California, San Francisco in 2020. So I currently work in a private practice, large multi-specialty orthopedic group called Ford Orthopedic Institute. We're based out of Tampa, Florida. I'm actually in a kind of a pod of that in Clearwater, Florida. And I work mainly out of one hospital and a few surgery centers, and I do complex spine surgery and everything that involves, as well as minimally invasive type stuff and non-operative care for the spine.
And has working in surgery been exactly what you thought it was? Was it something that, I think when people, I can imagine when people go into medical school, they have this idea what surgery is, and then they start doing it and they're like, this is different. And then by the time when you get through it, then you're like, okay, well, this is still different. I'm still learning. So I guess from your perspective, has it turned out to be exactly what you thought it was, or what have you learned?
Yeah, I think it changes at every phase of your training, right? So you've got medical school or even before that, where you're I want to be a surgeon, and then you get to do your rotations, and it's a cool experience. And coming from an athletic background, you kind of like that team aspect of fixing a problem and doing it all together. And then you get into residency, and you're starting to do this stuff yourself, but you still have assistants and things like that. And this next step is you're in fellowship, and you're really kind of honing in your skills. And then it just goes it's just thrown out the window when you go into practice, and it's all you. There's nobody to look, nobody behind you to kind of guide your hand, or you got to fix these problems on your own. So it's an ever evolving discipline, and I think that's part of what we love about it, right? It's something that you're always kind of improving and looking back on what you could be doing better, and it's a lot more than I thought it would be, probably, I guess would be what I'd say. But it's been a great experience, and it's been a lot of fun.
One thing I always enjoy that people have mentioned is practicing physician or practicing healthcare role. And there's a reason behind that, right? You're always constantly learning. You're basically practicing something to get better at it as you constantly do it more and more. Did you know that you wanted to become a spine surgeon right out of, or going right into medical school? Or is this something that kind of came along as you're going through residency and so on?
No, actually, I was pretty convinced I was going to do sports medicine, orthopedics. So kind of working with athletes and whatnot. That was just kind of me coming out of college. That's who I shadowed. That's kind of what the experience I had. And then as interns, we are required to do a vascular surgery rotation. So my vascular surgeon in residency is actually my current vascular access surgeon, which is kind of a full circle, kind of cool. I was his intern, and now he's my co-surgeon. Tomorrow we have a case together. So that's been kind of cool. But I got to do cases with him, and we would my spine attendings in residency would obviously be doing the spine part of the procedure. So I would just stay. And I kind of got some early on exposure to spine surgery, and thought, oh, this is really cool. Every surgery is a little bit different. This morning I spent my morning looking at my cases for tomorrow, and everyone's a little bit different. You got to figure out, what your goals are for each surgery. So, orthopedics, there's a lot of great procedures. A lot of them are very cookie cutter, and that's what makes them so good. Because a total knee, if done correctly, it's the same surgery every time. and it's reproducible outcomes, right? So spine surgery is very different. Everyone has to kind of be looked at a little bit differently. So I think that's kind of what really drew me to it, the kind of the complexity of the pathology.
And it's just because of the structures and how obviously the spine is crucial to
Yeah.
just doing things on a day-to-day basis. But is it just because of the lack of space that you're dealing with? Is it just like so many contextual factors? I suppose, like what makes spine surgery more difficult than other surgeries within orthopedics?
Yeah, I mean, I think part of it is the structures, right? So you're working around nerves that can't be manipulated too much, and you can obviously have a neural deficit. But then the other part of it is figuring out what you're trying to fix and like figuring out what the problem is. So there's multiple different areas where a nerve can be pinched. There's multiple different ways that a spine can be, either unstable or malaligned, and figuring out which part of those pieces of the puzzle are causing the problem is kind of the most important part of fixing spine and spine surgery. So if you can do a successful fusion, but if you're not doing it for the right reasons, it's not going to have a successful outcome. So I think that's
Yeah.
probably some of the most important, the hardest part is like figuring out what's the right thing to do.
Yeah, and I'm sure just constantly figuring and understanding like what are the contextual factors that make a successful surgery, and
Yeah.
what is the actual problem going on? Because even as a PT, not I can see a radiograph and patient come in and say like I have this and this, and it's like, okay, is this actually contributing to your pain, or are you just
Right.
having these things and this I need to do other things? So I'm sure you're balancing all those things as well.
Right. Yeah. No, it's hard to actually, you can obviously look at some images and an MRI and you can see that they have pathology, but they could be having muscle spasms or SI dysfunction. I've early on in practice, I trained in a big scoliosis center at UCSF. And so I would start seeing, I still see a lot of scoliosis patients, and, a lot of them would come in and like, I'm young surgeon, fresh out, I already planned out my surgery. And, before I even see the patient, they walk in and it hurts over their SI joint, you inject their SI joint and they're better. So it's like, you can look at a horrible looking scoliosis x-ray, but it may not be their problem.
Yeah, and I want to get into radiographs later, and as well as shots. So we'll keep that kind of on the forefront of our mind moving forward. But maybe this just highlight like what are some of the main surgeries that you do on a day-to-day basis? I know there's a vast array of different ones, but I guess the majority, like what are some of the surgeries that you're seeing?
Yeah, so I mean, I'm in Clearwater, Florida, where everyone goes to retire, and so see a lot of degenerative pathology. So I do a lot of anterior neck surgery, ACDFs. Do a lot of decompressive surgeries just for people that have leg pain or spinal stenosis. Probably a lot of 1-2 level lumbar fusions. I also am probably one of the few people in the area that do like deformity type procedures for people that need scoliosis corrections and stuff like that. It's a lot smaller portion of my practice because there's not as much need for that as far as volume wise, but I do a few of those here and there. Those are much bigger surgeries, which are great. They're a lot of fun, a lot of planning is required, but there's a lot of risk with the surgery. A lot more complications can occur with them, but in the right people, carefully selected, they're life changing. So those are a lot of fun to do.
Overall, what do you see are some of the biggest misconceptions for spine surgery? I know I've had a lot of patients where even just like a knee replacement, they're like, this isn't exactly what I thought it was. And I wasn't expecting to be in this much pain and so on and so forth. And I guess like, what do you see that are some of patients like biggest misconceptions when they're dealing with spine or neck surgery?
Yeah, I mean, I think I especially as like a young guy, I see a lot of like back pain and neck pain that probably never need surgery, but they're coming to see a spine surgeon, so they're thinking maybe surgery is an option, and they walk in, they're like, I never want spine surgery, and I'm like, well, it's nice to meet you, I'm a spine surgeon, but I think that they hear that maybe it's dangerous or it doesn't work, right? Those are probably the two biggest things here, right? It's super dangerous or it doesn't work, and I think neither of those are necessarily true. It's just that I think we've had a sort of an epidemic of a lot of people operating, a lot of people in our field operating, maybe trying to fix a problem that may not have ever really been their main issue, or may not have been able to actually treat them. So whether or not they can have a surgery is one thing. Whether or not that surgery is going to make them better is another. So I think you have a lot of people that underwent maybe spine surgery that didn't get particularly better, and then that news spreads like wildfire way faster than the people that have a great outcome. So And I think that's kind of a little bit of, especially in the Tampa, Florida area, we have a lot of laser spine institute that kind of went to the wayside. And a lot of places like that were, maybe stretching indications and trying to, be a little bit more aggressive in fixing people when maybe they could have gotten better with non-operative care, maybe not, but, then I think we're kind of learning a little bit who to operate on and who not to. I mean, that's an ever evolving field, but it's probably the two biggest misconceptions is the safety of spine surgery. It just sounds dangerous, right? It sounds, and then, the efficacy, like, is surgery effective?
Right. And I remember when I was a student, one thing that I saw was for some reason, when I was in PT, I always saw like almost like a negative outcome with low back pain, low back surgeries when I was a student. And I was like, why am I like, is a surgery like not going as planned? And, later to come to find out, talk to other surgeons, like you said, like usually a lot of the time when they have an unsuccessful surgery, they go to PT or they just like they continue to try and figure something out. And so like I was almost like I was seeing a biased sample size of the people who were probably the most loudest
100%.
and were probably the people who were getting they were just having a positive outcome to surgery because maybe they didn't get the right surgery for them. Maybe they had a preconceived notion of like their viewpoint on pain and so on. And so for other providers who may be seeing similar things or very young in your career, it may just be you're seeing a very skewed sample of like how successful spine surgery actually is.
Yeah, no, I think that definitely plays a role in it because the happy ones they're happy at home, right? They're
Right.
good. They're they're living their life fine, and then the ones that didn't have as good of an outcome, you're trying everything you can to get them where they want to be. You're back in PT aggressively, you're trying to figure things out, and then I think probably a lot of it is expectations, which I think is probably one of the most important things for surgery. Is like, what's your like goals for the surgery, right? Like, what is your goal as a patient to get out of this surgery? And if you have you have just low back pain and degenerative disc disease, and you want that to be cured, you're not a good surgical candidate, right? Because we're not great yet at correcting just isolated back pain that's a degenerative. Like you get arthritis in your knee, you replace your knee. It does great for most people. Very successful surgery. Hips are even more successful, right? But it's much more. Those are much more simple joints to fix versus isolating where that pathology is coming from in the low back. As you see these patients all day, every day. Is that figuring out what's their actual complaint and what's causing it. Whether it's musculoskeletal, is it their facet joints, is it their disc? They're all maybe degenerative. They all may have issues, but which one is causing it? Maybe it's all of them, right? So.
Mm. Yeah. And well, before we kind of get into like the nuance of like determining which and which, you had mentioned that that spine surgery really necessarily isn't dangerous, but I mean, there is some danger to it. And so
Yeah.
when you have someone going into surgery, you obviously have to explain, what you're doing and, the dangers behind the surgery and so on. And would you classify spine surgery being dangerous? Does it depend on the surgery? Does it depend on the patient and so on? I guess like, how would you, it's kind of a philosophy question too, just in the sense of like, you also don't want them to feel like this is going to be, this is going to, I feel like if you tell them early on, this is going to be really a challenging part moving forward, it may kind of like dampen their ability to recover in some instances. I don't know, like what are your thoughts on that and like how you view like how dangerous spine surgery is?
Yeah, no, I think it's a fine line, right? 'Cause I don't think spine surgery is necessarily dangerous, right? I think that's the wrong word. I think that there are a lot of risks associated with, you know, operating around the spine, and it depends on the area where you operate on. The risk can be higher or lower, right? So in the low back, if you have a disc herniation and you need a micro discectomy, that risk is significantly lower than if you have spinal cord compression in the neck and you need that to be improved, right? So, the risk of correcting a, spinal deformity and going around and resecting some of their vertebral body has a much higher risk. So there's a graded of risk. I wouldn't say again, it's necessarily a dangerous surgery. I think that we have evolved significantly in our ways to keep surgery safe. We use, neuromonitoring in surgery for most of our cases where we actually have a tech that's monitoring the nerves and the spinal cord, the whole case. So they can tell me if we're manipulating the nerve root too much, or if we're close to the spinal cord, if we have signals that kind of start to diminish, especially when we're doing really important parts of the surgery, which would be like, either correcting a deformity and taking out some bone that's around the spinal cord, or maybe trying to remove a disc herniation or something like that. So I think that they need to be aware that of the risks. And I explain, what the most common risks are, the consequence of those risks, and then the chance that that risk happens, right? I think those are the kind of the important things people need to know, and they need to hear it in kind of more, I guess, layman's terms to understand what, this could happen, this could be the outcome, and this is the chance that it could happen. And I think that that's super important to going into surgery is understanding the risks of what you're undertaking, because any surgery has risk of complications. It doesn't make it a necessarily dangerous surgery. It just means that that's kind of the inherent part of doing surgery.
Right. And I also want to expand upon what you meant by understanding that sometimes if you have degenerative changes in a disc herniation, it may not necessarily correlate with pain. And I guess it can be confusing from the patient, because the patient can look at their MRI and they'd be like, well, right there, it's right there. You can tell me that that's
five
the part
disc bulges. Yep.
Exactly. Yeah. So
Yeah.
that's the pain. So maybe just kind of expand upon what you mean by, like, it's difficult to kind of clarify what the source of pain is coming from.
Yeah. So, I mean, specific pain generators in the spine, they have certain kind of characteristics, right? So, flexion mediated pain is typically discogenic pain. Extension pain when you're going backwards, is typically the facet joints, those little joints in the back of the spine. And then nerve pain, which is what we're really good at fixing, right? Like if you look at historically, what are we really good at? Like we're good at fixing leg and arm pain. And so nerve pain, I try to explain it like a light switch. Like I know that if I turn a light switch off in my room right here, that it's going to turn the light above me off, right? It's not going to turn the light in my daughter's room off. It's not going to turn the light in the playroom off. Like I know what it's going to do. So if you have a nerve being pinched and you have pain in that distribution, then I'm really confident that that's probably causing your pain, right? If you've got, atypical pain, and that's when we start investigating more, right? That's when more investigative exams or injections come into play, and diagnostic type things to figure out, well, is that really what's causing your pain, or is it something else?
We need to be obviously continue asking questions and continuing to look at the research. But I guess one thing that has risen within the field of physical therapy is you are not your MRI. And, and usually we use this explanation for people who are experiencing chronic pain, more or less, just for the simple fact is people can develop this relationship with their MRI and being like, I'm a person who has a disc herniation. I'm a person who has spinal stenosis and so on. And I guess, have you seen patients like that? And have you tried to work on like changing this mindset of like, you are not necessarily your MRI?
Yeah, I think that's exactly where kind of the same thought process that we have as well. And it's hard, right? Because, and that's why we're actually UCSF, before I left, was one of 3 institutions that were part of the backpack, which is a new NIH grant. And it was tens of millions of dollars that was given to 3 institutions to study back pain and to create algorithms of what to do about back pain, right? Do we get x-rays? Do we send someone to PT? And then, if they don't get better after 6 weeks, do we get an MRI? Because you get an MRI and you're going to find something, right? And then if you find something, if you're looking hard enough, you'll find someone that's willing to fix it and hope that it'll make it better. Mm-hmm. And it's not malicious. It's just, well, someone comes to see you and they're like, well, I've seen 3 surgeons. Nobody wants to help me. Can you help me? And you'll find someone that's going to try and help you, and then you're not going to get better. And then that's that patient that says spine surgery doesn't work, right?
Right.
So, it's hard because you try to explain to these people that, that it's something that I tell them. I say, you keep looking, you'll find somebody that will try and help you, but it may not help you at all. And there's a good chance that it won't help you. So it's trying to explain to them, that the MRI doesn't necessarily mean that needs to be addressed, right? It's a very hard problem because they see it now. Now it's like it's mentally, that's an issue, and they're in pain and they just want to get better and they want a solution. And the hardest people to fix are those, right? Because it's like you have to convince them they need to go see you, and they need to spend 6 weeks dedicated doing it, and it's probably going to hurt. Like it's not going to be a lot of fun, but then you're going to get through it and it's going to be better. And they're like, well, I can go to a chiropractor and it feels better, which is a great option for symptomatic relief and things like that, or they can go see a massage therapist and get better. Again, these are all really good components of treating back pain and neck pain, but it needs to be coupled with all of this. Like it needs to be like a complete approach. You can't just go see a massage therapist and then just call it a day. Yeah. You can't just go see a physical therapist and call it a day. You need to do your exercises. Like it's a whole thing, right? So, and I think that's a hard thing where they're just like, well, why don't we just do surgery and fix it? And that's just not the way it works. And I think that deep down they understand it, but they want to get better, right? And that's the hardest part.
Yeah, and it's interesting for me because in my position, I have often a significant amount of time with patients. I mean, usually see over the course of time, 6, 8 hours, sometimes longer, where over the course of a couple months where I'm seeing these people to explain what's going on. And I can kind of get into some of the lifestyle factors. But from a surgeon's perspective, I can imagine that maybe you're limited in the amount of time and things that you're able to discuss, and like how this is going to be a point in your life where you really need to focus on many different things in order for you to get better. And do you feel like that's something that needs to change within the realm of surgery and like educating the patient earlier on, or do you think that should be dished out to the PT, or just as a collective whole, we need to be more like working on this problem of like understanding that this is going to be a journey and this is going to be something that you need to work, like continuously work on?
No, it's a good question. And I think it needs to be a collaborative effort. It needs to be everyone, right? Because the problem is that, in a perfect world, I really shouldn't be seeing someone that definitely doesn't need surgery, right? It just has chronic back pain. Like that's a waste of their time, a waste of my time, because I can't help them, and so like, then it takes away a slot for someone that I could potentially help. But that's a downstream effect. It's not the patient's fault. It's not the referrer's fault. It's just the fact that, we have not streamlined how to take care of back pain, right? And that kind of is the goal of the backpack is to figure out how to streamline this and how to put all the providers together, like, coupling all modalities, coupling pain management, physical therapy, chiropractic, like all of this, and having everyone on the same page. Like, hey, look, they've done this. Now that the data says that they should do this, right? So because the people that you see in your office that aren't surgical, sometimes they're a lot harder than the one that has a massive disc herniation that has failed 6 weeks of conservative care. That's an easy one. I give my spiel on surgery and how we're going to fix it, versus someone that has seen multiple different people. They've been to physical therapy. They've had injections, maybe injections they didn't even need. And they've done chiropractic, they've done it all and nothing's helped. And then I have to explain to them that I can't help them. So that's a hard thing to do. And it's a hard conversation to have in a 15-minute time slot. I totally agree. So I think it needs to be a collaborative effort. I mean, I think, they need to hear it from everyone. And they need to because they need to see that it's everyone on the same page, right? Because then if you have someone telling them one thing, someone telling them another thing, then it's just, they don't know what to believe.
And it's especially if the providers aren't talking to each other and they're not saying the same things, and they're like, I can definitely help you, or like, I can maybe help you, or like, I'm not the right person for you. As a patient who has no experience and understanding just like how to take in information and understand like, what am I going to do next? It's got to be incredibly confusing and frustrating.
For sure.
Let's just say we have some candidates who are like thinking about surgery, and like, these are people who are wanting to get into like, or maybe they've had low back pain, they haven't had success with conservative care. What are some things that you would say that can make them the most ready for spine surgery? And are there things that you already tell patients that they should be doing to be ready for spine surgery?
Yeah, no, it's a good question. I mean, like, obviously health optimization is key. So like, I don't operate on anyone electively with an hemoglobin A1C, diabetics over, 8. That just increases the risk of wound complications, infection, and things like that. So, optimizing your health, right, is super important. And then any patient that can physically do it. Sometimes you have people with severe weakness or other issues, but anyone that can do prehabilitation, we recommend prehabilitation. There's a lot of literature out there on pretty much all orthopedic procedures that these people do a lot better if they've been prehab, right? So people that, and that for a lot of insurance is a requirement anyway. So it's a win-win if you can go ahead and, strengthen those muscles that I'm probably going to cause a little bit of damage to, and, back up your core and be able to really kind of get up and get going a lot faster. I think those are the ones that recover a lot better.
And how important is that developing a relationship with your surgeon? Is that something that, I know with like knee surgeries and hip surgery, it's kind of like, hi, I'm your surgeon. This is what we're going to be doing, and I'll talk to you later. And then the follow-up visits maybe in like 3 months, and you talk to the doctor finally again. I guess like how important is the relationship with your surgeon in spine surgery?
Yeah, I think you just described my hip partner perfectly. It's one of my best friends. So, No, I think it's super important, right? Because it's kind of like a marriage, like you guys are kind of stuck together through complications, through good and bad. So I think it's something you have to be super comfortable with. You need to be comfortable with your surgeon. You need to be comfortable with your patient too. Like you need, like sometimes there are people that have really, really good pathology that you just don't, if you two aren't comfortable with each other, that may, that could cause issues down the road, right? So you need to be, there needs to be an equal comfort level. And for me, the comfort from the patient side is that they are able to articulate the goals that they want to achieve in surgery. And I think that's like one of the most important things for successful outcomes, because now I know what your goals are, and I can either tell you, hey, I can't achieve them, or this is how we're going to achieve them.
Mhm.
And this is what the road looks like, right? So I think it's very important for you to be, comfortable with who's going to be, treating you.
Yeah, absolutely. And do you see literature perhaps supporting having a good relationship with your surgeon before and after, or is it kind of just like a mixed bag at this point?
There's been some papers that have talked about, we look at like ODIs, NDI, outcome scores, SF-36, kind of those global metrics, and there's obviously improved metrics for these people that have that would describe their relationship as good with their surgeon. Does it directly translate to a good outcome? No, I mean, because you can have a lot of really good surgeons that maybe you don't get along with that are going to do a fantastic job, and you're going to get better. But I think it's an important part of a proceeding with an elective procedure, especially where this may be a long 3-month undertaking of getting them to where they want to be.
Yeah, and we've discussed kind of the build up to and kind of a little bit of the after of a spine surgery, but I guess like what are some metrics for surgeons in regards to like a successful surgery? Obviously, having no pain is something that can be a
Right.
positive indicator whether it worked or
Yeah.
not. But I guess like are there like criteria that you guys look like use to try and indicate whether this is a positive surgery? Perhaps you had a patient who had low back pain and they had ridiculous pain all the way down their leg. They had low back pain. You got rid of the ridiculous pain, but the pain is kind of like still sticking around. So I guess like how do you determine success within spine surgery?
Yeah, I mean, obviously we try and use metrics. So Oswestry Disability Index for back pain, the Neck Disability Index for neck pain, things like that. We look at their actual reduction in pain. I think that's all good for research and metrics, but the patient doesn't really care about research. We do, for advancing the field. But I mean, really, I think it's it comes down to, did we meet the goals of surgery? And I sit down and I talk to them, especially a patient that has neck and back pain. They have neck and back pain, so they have a 4-5 L4-5 spondylolisthesis, a slipped vertebrae that's unstable, that can cause mechanical back pain, and they have nerve pain from that as well. So goals of surgery are to stabilize that segment, right? Decompress the nerves. And they come out of surgery and they have no leg pain and they have back pain still, and it's diminished, but it's there. And that's something that I discuss with these patients before surgery. It's like, you may still have some back pain. Back pain is a chronic, endemic, basically. That you see it all day, every day. So having that, and if they have that in the back of their head before they go through surgery, they're like, look, there's a 85% chance that we're going to make your leg pain better. Back pain, I think there's a good chance it'll improve, but how much it'll improve really kind of depends. And then they wake up and they get through their post-operative time, and they have the same expectations that we do. So our goals are kind of aligned. So I mean, I think if we are able to kind of improve quality of life and achieve reasonable goals of surgery, I think that's what makes a successful surgery.
And you also were starting to talk about just like if you if you have a problem and you go to find somebody, you're going to finding somebody who's going to try and solve the solution to your pain. And i.e., this is like you're going to be able to find a surgeon who's going to cut you. And I guess have you seen a difference between surgeons who are older and younger? And would you say that all spine surgeons are the same, or do they vary?
No, I mean, there's definitely a variance, right? So, even in the fellowship realm, different fellowships have different strengths. So I think you kind of come out of fellowship kind of trained like your mentors. So you may have these predilections for certain things, or for certain types of surgery. You think you definitely have some spine surgeons that are more interested in doing tougher surgeries, revision surgeries, and things like that. I probably kind of fall closer to that realm where I do quite a bit of like revision stuff, and that is a little bit because you're young, you kind of want to help everyone that comes to the door, so you kind of take on everything. And then you've got you've the older surgeons. As far as differences, I mean, my senior partner trained at Jefferson 30 years ago, spine surgeon, and there are some nuanced differences the way he does things and the way he works with patients, things like that, but it's all kind of to achieve the same goals. And we do some surgeries together. I've introduced some new technology to him, he's introduced techniques to me, right? So you're always, I feel like most of the good surgeons are still learning, and they're still, they're willing to adapt to new things. He uses robotics, he uses navigation. Now that I'm here, I do a lot of things under CT guided navigation. So there's definitely nuances and differences, and there's definitely surgeons that have predispositions to certain things. Like some of my mentors, all they did was correct deformities and scoliosis, and that's all that was seen in their clinic. Because if someone comes in with an isolated one level disc herniation, you're taking up a time slot for someone that could see my mentors to be fixed somewhere that most of the people aren't going to be doing that surgery. So right. I think you do have some subspecialized surgeons, but I think most of us as spine surgeons want to be able to help anyone that comes in and kind of fix whatever comes in the door. So I think that's kind of what kind of drew us to spine surgery, right? So it's not just a hip and a knee replacement, or a revision hip and a revision knee replacement. There's a lot of different things that you have to kind of be versed in.
Well, you're dealing with the spine, and we're talking about kind of like differences between surgeons in general, which doesn't seem like there's too many, but obviously everyone practices a little bit differently. But one thing that can maybe be confusing is like the difference between like a spine surgeon and a neurosurgeon. Obviously neurosurgeons work on various parts within the brain and other locations, but you're also working around very close structures to the nervous system, and you're helping to relieve a lot of issues within the nervous system. And so I guess like what would you describe some of the differences between a spine surgeon and a neurosurgeon?
Yeah, so most of the difference is training, and the way they kind of got to the same place in life. And we both obviously treat the same pathologies. They have the ability to treat brain pathology. So from above the cervical spine. So, but what you'll see is, just like in orthopedics, we have subspecialties such as sports and total hip replacement, total knee replacement, things like that. Is you have subspecialties in neurosurgery, and then you have those neurosurgeons that kind of draw towards spine surgery, and those that draw towards brain surgery, or true neurosurgery as we think about. So they spend 7 years, right, in residency doing brain and spine, and we spend 5 years doing orthopedics, and then a year afterwards doing a fellowship in dedicated spine surgery. And historically, I think the difference was a lot bigger, because back in the day, before my time, the orthopedic spine surgeons we were good at hardware, right? So we were trained in biomechanics. That's our background. So we understand different metals and what can go where, and how to put in screws and cages and things like that. And so the neurosurgeons, like if you take, for example, an anterior neck surgical surgery, like a fusion, maybe 30, 40 years ago, the neurosurgeons would go in. Sometimes even the ENT surgeons would do the approach. The neurosurgeons would go in and decompress the neural structures, and decompress the nerves, and then the orthopedic surgeon would go in and put the hardware. So, and then I think both of them got to thinking, well, hey, I can do this part, and they're like, hey, I could do this part, and so our fields have slowly merged, and now, a lot of my colleagues are neurosurgeons. And I collaborate with them. We do surgeries together sometimes in UCSF. Actually, every orthopedic spine surgeon pairs with a neurosurgeon, and they do a lot of dual surgery, because they both have different skills that they kind of bring to the table. But as far as from a patient standpoint, for the most part, if you're seeing a neurosurgeon that does spine surgery, they are pretty much they're doing everything that a spine surgeon, an orthopedic spine surgeon does, and vice versa. So they're both very well trained in the field of spine surgery.
So no real consideration, just more of just like if there's you're not going to have, I guess, like if you go to a hospital and they have a neurospine surgeon and they're doing all like the orthopedic, is there going to be like a neuro-ortho spine surgeon who's doing like all the spine surgeries, and then other places they'll have like an ortho spine surgeon? Is that kind of how it goes?
No, so I mean, for example, at my hospital, there's nine spine surgeons. 4 of them are orthopedics trained, and 5 of them are neurosurgical trained. And then of those 5, probably 3 of them do a fair amount of spine surgery, and then 2 of them do a large amount of whether it be neurovascular interventional or brain tumor surgery and things like that. So they kind of, can they do spine surgery? Sure, and they do it as well, but a main proportion of maybe their procedures lean one way or the other. But I think you see that's pretty much where everywhere you see is there's a kind of a good mix of neuro and spine surgeons.
And you had mentioned that something that you're started to do more and more is just like guided things with various technologies and using the use of robotics. And I guess like how has robotics started to influence some of the spine surgeries that you're doing? And what are you seeing within the field of spine surgery?
I think robotics is really in its infancy in spine surgery, where it's been around for over a decade, but it's still at a point where we've got a long way to go. So I use some robotics, use some in my fellowship, and it's become an instrument to plan surgeries better and to kind of place the screws when you're doing a fusion successfully. Now, most spine surgeons are well trained in placing screws. So I think some of the, maybe the older generation are slower to adapt to this type of technology because the argument is, well, I can put a screw in really well. And the studies show that, right? So it's more of a paradigm. It's more of a philosophical kind of shift in, well, we're going to use this software to help us plan our surgery and maybe be more thoughtful about certain things of the surgery and certain angles we're trying to correct and certain things that, where exactly we want the screw to be for reducing adjacent segment disease problems, things like that. It's not just putting in a screw. And so I use a lot of navigation. So I basically use an intraoperative CT scanner that scans the patient with all of us outside the room. So it limits radiation exposure to the staff and things like that. And then we basically use a navigation device that uses probes that kind of match up to a camera, and it can reference it in space. So there's a static spacer that references it, and then any of your instruments are mobile, and so the camera can visualize where you are in 3 dimensions using a CT scanner that was just done on the patient. So that allows us to again place screws and plan where we're going to place things in live time, which I think really helps with it helps with outcomes, and it helps with really being thoughtful on the type of surgery you're going to do. And I think we're really just in the infancy of developing haptic feedback and figuring out how to use robotics to help us, do decompressions and measure like how much bone resection we need to take to decompress the neural elements, but not destabilize the spine and things like that. And I think we're, 5-10 years from being at the peak of robotic spine surgery. So, which is kind of exciting time to be in. We're learning a lot, we're figuring a lot of stuff out. But it's definitely, it's not at a point where obviously the robot's doing the surgery for you. It's just kind of it's an assistive technology to help us, improve outcomes and surgery.
I had seen this one surgery, it might have been on LinkedIn or somewhere, where I saw it was like some guy in a different country was performing surgery on somebody from somewhere else. And do you think that that's going to be something that people are going to be able to do? Perhaps like a neurosurgeon in California is operating on someone in the middle of Oklahoma. Do you think that's going to be something that's going to be in the future? Or you think we're pretty far away from that?
I think we're pretty far away from that. Honestly, that's like a Da Vinci type robot that can, has the arms and that can do things. I think there's going to be certain things that you can do with that, right? Especially very tedious things, maybe repairing a dural tear that you can use the little arms to do, or maybe excising a brain tumor or an intradural tumor in the spinal cord and things like that. But I think we're a long way away from being outside of the surgical field and operating.
Got it. And, we've been talking about how many factors go into low back pain, and we're also talking about technology. Do you feel that AI is going to start to have an influence on considering all these factors and determining whether or not surgeons are doing the right thing, and how we can perhaps have better outcomes moving forward as surgeons, PTs, and others?
Yeah, I think that's probably going to be the most important thing we're going to see in the next decade. And my institution I trained at was very, very big and from the forefront of using AI to develop kind of algorithms and improve outcomes, right? So I think that if we can get better at picking surgical candidates, then we're going to improve outcomes, right? We're going to see more people being happy with surgery, more successful surgeries. And I think that comes down to the fact that we are doing our best to investigate pain generators and see if we can fix those, whether it be from a non-operative standpoint, physical therapy, medications, or from a surgical standpoint, and which ones are going to do better with what. And so if you start to develop an algorithm, a tree of patients, and that you can cluster those patients into specific categories. You've got a 50-year-old male with these radiographic and MRI findings, and you've got data on 1,000 of those exact basically phenotype patients, and you can be like, well, this was their outcomes for each different thing, and you can say, well, this would be successful in this amount 65% of the time or 0% of the time, right? So it could help us to kind of make a decision based on past experiences, and not just my past experiences, but past experiences of my colleagues. And once it becomes a collaborative effort, we obviously can expand that amount of people that we've helped, and we can look at that like database and be like, well, I think I can help you, or I don't think I can help you, I think that we should do this. So I think that's going to really, really be important in helping to improve outcomes and figuring out what the right, when it's the right surgery and what the right surgery is. A lot of times we do too much, when we're trying to correct a spine surgery or spinal deformity. And, we have, historically, we go to specific levels in the spine because we know that based on our past research that the incidence of an adjacent segment problem is higher in certain areas versus not in other areas. But, maybe some of these people will do really well with a smaller correction, just as well as they would have done with a larger correction, and we can save them a bigger surgery. It doesn't mean that they both didn't have successful outcomes, but you're adding more risk to the surgery and things like that. So I think we're going to be able to learn to tailor surgery a little bit more. And if you can do less, then that would be amazing. My mentors always said, it's like, you need to figure out when you can do less and when should you do more, right? So, and I think that's where AI is going to help us.
And I'm sure as a surgeon, one of the things that you do value the most is what your mentors have to say to you and the things that they try to influence on you. But I'm wondering, the day that comes when AI is perhaps so good at determining outcomes and figuring things out, whether maybe a discrepancy between like someone who's been doing surgery for 30 years and then AI is coming along and like saying, well, I don't know. And do you feel like there's going to be a big balance? There's going to be an issue between like people coming in with AI technology to say like, hey, like we think you should be doing this, but like, you don't know shit about anything. So why are you telling me how to do my job? Do you think there's going to be an issue with that moving forward?
I think that we actually discussed this. I was just in Park City with a meeting, and we talked about like AI and big data. And the biggest concern about this is from an insurer standpoint, right? Because they would love to get AI. Like they already do this, right, to figure out who's insurable and who's not and things like that. And so they would love to have AI data on patients to know who they should deny surgery for. So we have to stay on top of it as surgeons. We need to control the narrative because we are the ones that are collecting the data and are using it. So I think it's going to be a fine line of using the data correctly to kind of aid in your clinical assessment. It's not going to take place of, obviously a clinician's assessment, but it'll help you narrow down specific things when there are a few options maybe at play. But yeah, if we don't keep a close lid on it, and we don't control the narrative, and we don't bring this to the insurance companies and to the rest of the population, then it could become a big problem.
Yeah, one thing I fear that it's almost like taking the art form out of surgery. Like what you guys are doing and what you're practicing on a day-to-day basis is like incredible, and it's something that's amazing. But if some technology decides to come around and be like, you need to do this now, it's almost like you're taking the art form out of surgery, and you now become a puppet and a subject to this piece of technology. And I'm sure that's got to be I'm sure you guys can see the writing on the wall long before it happens. But I guess like is it just having these discussions, do you think that's going to hopefully minimize and stop this from happening?
Yeah, I mean, I think that you have to keep it in the back of your mind, and it has to be on the forefront of us figuring it out. But I don't think you ever lose the art form of surgery. If I think that part you still need. Like I think that there's still that human component that makes surgery so special. Like having to figure out exactly what needs to be done. I think it's just it would be a great added tool, and if that's the way we can treat it, then I think it's going to be instrumental in helping outcomes. But I totally agree that it's a very fine line, something that could be easily exploited in the future. and something we're gonna have to be very vigilant of, our societies and things like that, of keeping that from getting out of control.
Absolutely. And obviously technology is really important, really good at managing all these factors. And, you've dealt with many people with low back pain and neck pain. And I guess I'm more just curious to know like what your perspective is on this. And like, why do people have so much neck pain? Why do people why is low back pain so chronic? It's something that happens. It's one of the major contributors to healthcare costs. It's one of the major contributors to many different things across the US. So I guess in your eyes, like, what do you think? Why are so many Americans having, and people in general, having low back pain and neck pain?
Yeah, no, it's incredible. It's like one of the top GDP expenditures in healthcare. It's like the number one reason for people to be out of work. And I think there's a lot of reasons for it. I mean, I think a lot of it comes down to what our spine does, right? So, when we look at like spinal harmony and spinal alignment, our goal of our spine is to keep our head over our pelvis, right? We're upright creatures. And so that, I think, it is inherently a task that we have to continually think about and we have to continually perfect. And so anytime that your spine is out of alignment, then you're going to use specific, structures in your body to help correct that. So as your spine ages, which can be accelerated from injuries, it can be accelerated from postural issues, from weight, from all kinds of things, right? Then you've got to compensate for this aging spine. And then you've got musculoskeletal problems. So you've got your muscles. Number one, first compensatory mechanism is your paraspinals, right? So they're the ones that are going to try and keep your head over your pelvis. And then you've got your hips. Your pelvis is mobile, right? It can retrovert. So you've got now you throw in pelvic issues, and then you've got your lower extremities that can help you kind of ambulate and walk. And then you have all of these compensatory measures that continue this cascade of throwing you out of alignment. And unfortunately, we aren't very proactive in doing this. So if we don't do everything you can to create an environment in your body as well as your lifestyle to protect this, so you don't work on your paraspinals, you don't work on your core, your posture's bad. One of the biggest endemics in that we're going to see, I think, in the 21st century is this: we're looking down at our phones all the time, right? So that's going to be, we're starting to put out papers on that and how the way technology has changed neck pain, really.
Yeah.
I think that's a huge part. So I think it's lifestyle factors. I think it's we've especially lately. I actually was just speaking with some primary care doctors about how like this whole work from home thing has changed and has worsened back pain because we've changed the environment we're in. We're a lot more sedentary. So I think there's so many different factors at play that I think that's what makes it one of the most common things that we see. One of the most common things you see, one of the most common things a primary care doctor sees, other than maybe a runny nose. Like I think it's there's just so much at play, and that's why you see it from an 18-year-old up to an 80-year-old. And they're all for multiple reasons.
Well, one thing I want to maybe not even push back on, just want to maybe get a philosophy on what you think about this idea. I see people who do have posture abnormalities and they have, terrible posture, but they may not necessarily correlate with pain. And our bodies are very reactive to the things that we do on a day-to-day basis. And, obviously, like you said, if you're spending more time here, your body's going to start slowly going in this position. Do you feel like it has to do more with spinal alignment and like just like the skull over the pelvis, or do you feel that it's a response to your musculature not being able to tolerate that activity for a prolonged period of time? Because if you're in this position for a long period of time and you get really strong and be in this position, you may not have pain, but you have poor posture and so on. If you've been here, but now you're in this position, you've been working from home for a long period of time. Now you're having pain, but you still have good posture. So I suppose like, what do you what is your viewpoint on that? And do you think it's just a response to the body not being able to tolerate sitting in that position for long periods of time? I guess, like, what are your thoughts?
Yeah, I mean, I think probably it's a little bit of both, right? So I think you've got a postural issue where your body's out of where it would like to be in space, and then you've got muscles that are not working appropriately, so they fatigue faster. So I think that's a huge component of back pain. Is you see these muscles, your muscles fatigue from just not being able to keep up, and then they spasm. And a lot of back pain that we see is musculoskeletal spasms, right? Like it's just chronic fatigue of these muscles, and we're not using them correctly, right? Like you think about like the multifidus muscle, right? Like one of the tiniest little muscles in your spine, how important it is, and how do you train that, right? And that sort of thing. I think it's really, really important.
And do you ever see physical changes to musculature when you're going into spine surgery? And maybe there's research that looks at cross-sectional areas on various muscles when you're doing it surgery. Do you see actual physical changes to the muscles? Are they smaller? Do they have more like fatty deposits? I guess, are you seeing changes to, or maybe even correlations to people who have low back pain and changes to musculature?
Yeah, I mean, you definitely do. You see, and you look at the not actually in surgery, I wouldn't say like live time, but you look at a cross sectional imaging like an MRI, and if you're looking for it, you'll see myopathy a lot more than you would expect. You'll see these people that have fatty changes in their paraspinals, especially the multifidus. And then if you look at like surgical patients, right? So we know from studies as well as looking at imaging that if you have to take your dissection over the facet joint, so a wider exposure, you denervate the multifidus, which is a significant problem from a musculoskeletal standpoint, right? It's a very important tiny little guy there. So when you denervate those muscles, you start to create problems that have a hard time with recovery. So that's where you see this kind of, trend towards minimally invasive surgery, where we're trying to do as little as we can and protect the muscles. A minimally invasive procedure can be this massive skin incision. That doesn't matter. Your skin heals great. It's the muscle denervation and the fascial planes and protecting those that's really important. I think we're learning more and more about that. And I think we'll see more and more of this cross-sectional imaging studies to look at like the actual denervation of the muscles themselves. So from a surgical standpoint, I think that becomes really important. But even prior to surgery, I think, there are these people that have these weird myopathies that just show up, and there's actually UCSF, where I trained, was doing some research on looking at maybe genetic phenotypes of like just why are some of these people having this, and are they predisposed to low back pain? I think that could play that doesn't obviously play a ginormous role, but it's definitely things you can see.
Maybe just explain what a myopathy is before. Just in
Yeah,
case people listen, maybe
yeah.
like, what the heck are we talking about here?
Yeah, so basically it's any sort of disorder, whether it be from vascular, neurologic, or idiopathic, that causes muscles to kind of atrophy and die and things like that. So,
And then you had mentioned fascial planes. We didn't really touch on this at all, I guess. Are there literature supporting the use? And I'm not really well versed in the whole idea of like fascial planes and so on. And I know within the realm of physical therapy, there's some practitioners and maybe even athletic trainers who use fascial planes to help strengthen. I guess, have you seen anything to help support that, or the use of of trying to train in that area, or what? I don't know if you've seen anything in regards to fascial planes in general. So I guess, like, what
no,
your take on that?
yeah, no, I mean, kind of where I was coming from was more from a surgical standpoint, but
Okay.
actually training fascial planes, no. It's interesting. Like actual specific muscle groups, you mean, kind of like that are
Kind of
separated by
more
the
like
fascials?
following fascial like patterns, like rotate, like because they they go in certain directions and so on.
Right.
The idea is to like do rotational motions. And again, I'm not well versed in this, so if people are
Yeah.
listening, be
No,
like,
it's, I mean, no, I mean, that's interesting. I think, obviously there's a lot we have to learn about, the way that our muscles function synergistically. And I think that's a key role in what you guys do in training these muscles and strengthening them the right way and stuff.
and we're talking still continuously about the low back, and obviously one thing that has become a huge issue, even tenfold during the pandemic, is the opioid use, as well as like medication and so on. I guess, how how have you seen the profession of surgery change in the use of pain medication?
Yeah, I mean, it's kind of made my job a little easier, right? So, I'm kind of limited to what I can do. As far as dispensing opioids, we can give them out for basically 7 days at a time. There's now classifications of like an acute pain versus chronic pain, and chronic pains are followed a lot closer. And so I don't manage any chronic pain. I think that it's a right. It's a problem, because it was an easy fix for a lot of people. And unfortunately it was things that, it's people that maybe shouldn't be just placed on opioids, that had actual problems that could be fixed. And it was just an easy solution. So unfortunately, yeah, I mean, it was just very sad how it all played out. But it's from a surgical standpoint, I think, some it's added some headaches, but it's made our lives a little bit easier to where, I mean, we kind of have our own policies to where, I mean, I don't want people on opioids, obviously. And, post surgically, they're going to need to be on it from anywhere from 2 days to, a couple months, maybe, depending on how big of a procedure it is. And, if we have patients that truly still need it, we work on getting them to like a chronic pain program or something like that, where we're hopefully still kind of weaning them and figuring out other modalities. But yeah, I mean, it's still a problem, right? It's just made it more of a hassle a little bit to you having to get refills and things like that have to be very short order and that sort of thing. But from a surgical standpoint, I think our goals have stayed the same of, getting people off of them as soon as we can.
Yeah, it's interesting because it's a useful tool, right? Like it's just if someone's in a significant amount of pain, they're trying to recover, an opioid can be a great way to get people to start, I'm assuming, moving again. And so from your perspective, after someone's gone through surgery, be like, yeah, let's get them some opioids a little bit just to get, the pain calm down so they can actually get over this hurdle and move forward with their lives. So I can imagine it's been difficult to kind of navigate and use responsibly this very powerful tool.
Yeah, I think we're getting better at multimodal pain. So I think that, we are seeing a reduction in our opioid utilization because we're seeing these people, like I use a bunch of different modalities. My anesthesia colleagues will give them preoperative medications that'll help with their post-surgical recovery. We'll do blocks, right? We spine surgery, we have blocks. We have we have a couple different fascial blocks and things like that we can do. And then intraoperative things, like I put topical opioids on the areas that we're doing surgery at, which reduces the actual PO opioid intake after surgery and things like that. So I think we're getting better at kind of working with the whole situation to reduce that, but it is still a useful tool, and it'll continue to be just one piece of the puzzle of keeping their pain under control post surgically.
And we're discussing the management of pain just kind of either after surgery. But one thing that physical therapists have started to really dive into, and I'm sure you guys seen it as well, is just pain education and as a mode of pain relief. And, there's been some early on research that support that even educating patients on pain can be a way to help reduce pain. And I suppose, is that something that you guys are starting to include within your practice, maybe post-care or even pre-care, or is this something that needs to be continued to kind of be looked at? I guess, what are your thoughts?
Yeah, no, I mean, that's I think that's really important. I think education is super important in all aspects, and especially with pain. So I mean, we try and do the best we can, I think, of explaining post-surgical pain and like the types of pain and what to expect. I think expectations are super important, right? I think understanding that what type of pain you're going to have, this pain is going to be different, this pain is temporary, things like that. I think it's super important, but I think it's definitely an ongoing field of research for us.
Well, Mike, I really appreciate you spending time with us today and really answering many questions in regards to the field of
thanks for having me.
surgery and asking. I just have a few more questions to kind of finish off with the closing remarks for the podcast. So this is called the Health Me to Health Me portion of the podcast. I ask these questions with everybody and give you a little bit of time to take a look at these questions before we get started. First question: if you had the attention of everyone in the world for 30 seconds, what would you say?
Yeah, I saw that question. I was like, oh, that's a cool question. Now, I think probably would have to thank my kids and wife for all their support, because I definitely wouldn't be there without them. But I would probably, from a spine surgery standpoint, I'd want to tell everyone that, to think about the importance of, like we've talked about, of maintaining a healthy spine. If you can spend 10 minutes a day stretching and just working on some easy things to help strengthen your core and your back, I think it'll go leaps and bounds to staying away from seeing me.
I couldn't agree more. Well, I usually say that with patients too. I said, my goal is for you to, never see me again, not in a bad way because I don't like it, but because you're out there living your life.
Exactly.
Second question: what book do you recommend, whether a book you're reading now or in the past?
Yeah, so I just flew through Jack Carr's books. I don't know if you've heard of him. He's a ex-Navy SEAL, and he wrote like a fictional series called The Terminal List. And it started Terminal List, and it went through like True Believer and then Savage Son. But basically, he was a Navy SEAL, and he created a fictional story, but everything is like super realistic. So if you like that kind of stuff, you'll blow through them really fast. I went through 4 books in like 2 weeks. So
I read the Extreme Ownership by Jocko. I forgot his last name.
yeah,
And
yeah,
I, my buddy recommended the book to me, and after reading that book, I was like, I am the leader of everything, or I am responsible for
yeah.
everything in my life. I'm like, maybe I should take a break, like have a little bit of an interlude between reading books from Navy SEALs.
Yeah, no, they're definitely intense. But I'm reading Talent is Overrated right now. It's good. So far, it's a pretty good read.
Nice, good. Last question: where can people learn more about you and what we talked about, or just learn from you in general?
Yeah, so my website's clearwaterspinesurgeon.com. There's some information on there and some videos and things that I do, as well as on Instagram. I'm Clearwater Spine Surgeon, and then I'm on LinkedIn as well. So we're kind of we met up a little bit. So yeah, would love to chat more.
Mike, thanks so much for being on the podcast. I really appreciate it.
Yeah, yeah. Thank you for the time. This was fun.